Thank you, Mr. Chairman. Good morning. It's a pleasure to be here. I had a wonderful day yesterday looking around the Acropolis. What a fantastic location. I'm going to talk today about vasopressors. Just show my disclosures that you can see listed here, various grants and personal fees, but also to point out that some of the work that I'll be presenting is funded by the NIHR in the UK, who fund me as well. And their standard disclosure, the views expressed are my own, not necessarily the Department of Health or the NIHR in the UK. So if we want to know about vasopressors, if we want to know where we start, we could go to the Surviving Sepsis campaign and look at their guide. They've got vasoactive medications is one of the summaries they give here. And for those of you who don't think you can concentrate for the whole talk, you could summarize it here. I agree with really most of what they say. Noradrenaline is the first agent. Really no reason to be using dopamine. A bit about the alternatives. This is where I generally agree, but I'll spend most of the talk talking about just slight differences in the evidence behind this part. And the last bit about dobutamine, I'll leave to the next speaker, because that's all around inotropics. So it recommends upfront that norepinephrine is the main first-line vasopressor, and it comes from an ex-president of the ESICM, the SOAP2 trial, Daniel DeBacker-led, largest study in critical care looking at the vasoactive drugs. And although it showed no significant difference between norepinephrine and dopamine, I think many of us would suggest that maybe the norepinephrine was looking better as far as survival. But actually, the more interesting information actually comes from the safety data and the serious adverse events. And as you'll know, that there was twice as many arrhythmias with dopamine compared to norepinephrine. And that was whether it was AF, VT, or VF, were all nearly twice as common with the dopamine. So it made perfect sense that we dropped the idea of dopamine and used norepinephrine as our first-line vasopressor agent. But that's one trial, a very large trial, very important trial. But what about if we look at all of the evidence in a systematic review? The Cochrane collaboration have done that a few times. The most recent iteration was in 2006. And they've compared everything. They used norepinephrine, therefore, as the comparator. And you can see all of the individual comparisons laid out here in a standard sort of meta-analysis format. What I like about these analyses now that people are doing is a Bayesian network analysis. So when we've got multiple things to consider, rather the trials often compare A versus B, and B may never have been compared to C, but if you combine them in these network analysis, you can actually make these comparisons. So if everything else has been compared to norepinephrine, you can start comparing A versus C as well. And that's what they've done. And they put them here, used again norepinephrine as the comparator. And you can see that dopamine is tending to do worse. The confidence intervals as far as survival extend past 1. So it can't say it clearly leads to increased mortality, but there's a signal there that you tend to do worse with dopamine. Phenylephrine, the point estimate is very wide, but is on the same side. But the terlipressin and vasopressin, again, confidence intervals all crossing 1, but point estimates may be suggesting some benefit, and I'll come back to those in more detail. So their conclusions were that there's no evidence of substantial differences between the different vasopressors, so maybe we could use any of them, but they do clarify this effect of dopamine leading to the increased risk of arrhythmias. So that's why that is there. But are they all the equivalent? This was work from Gilali and Nunn, comparing norepinephrine with dobutamine versus epinephrine alone, published 10 years ago now. And they found, and their primary outcome, no statistically significant difference in outcome, 40% versus 34% mortality, but obviously with a p-value of 0.31. It was a small study, relatively 320 patients, but their conclusion was there was no evidence of a difference in efficacy and safety between epinephrine and norepinephrine with dobutamine. But I think it's important to consider the size of the trial and therefore the power, and even they write in their power calculations that they were looking for an absolute reduction of 20%. So if we consider septic shock might have a mortality of 40%, do we really think if we switch our vasopressor, we're going to halve mortality in septic shock. So I think it's an important study, but I can't say that we say the two drugs are equivalent when we're looking for a 20% absolute difference. And I think, and other people said this. Mervyn Singer, a colleague from London, said, actually, are all catecholamines equally good, or in fact, equally bad? And I'll come back to that. But I think it's important when you look at some of the other data around using epinephrine. There was a drop in the pH, and it was due to this rise in lactate that is well described you get when you treat patients with epinephrine. I'm not suggesting that that is a bad thing. It is a pharmacological effect of using epinephrine. But as we had a talk yesterday around using lactate as a guide, I find it very difficult if I'm using epinephrine and the lactate goes up when I've started it to know has the patient got worse or is it because I've started the epinephrine. So personally, I don't use epinephrine very often. And I think it's worth thinking about if you use lactate as part of your targeted therapy. But going back to Mervyn's comment, are they all equally good or all equally bad? Well, I think there's some new data suggesting maybe they aren't all equal. This paper come from Hannah Wunsch's group, looking at what turned out to be sort of an almost accidental experiment in the US, where they had a shortage a few years ago of norepinephrine. And some of the hospitals, the ones shown at the bottom, they had a period, I don't know if we can show it here, where they ran out of norepinephrine in certain hospitals, and so they had to use something else. And so they used phenylephrine, which is this yellow one here. And you've got hospitals where they didn't run out, and that's in the top. And so you've got a sort of experiment. It wasn't truly a randomized controlled trial, but it was a random event that led to them having to switch agents. And they've done some clever analysis looking at it, and they found that if you compared the patients who were treated in the shortage hospitals during that shortage period where they changed, mortality went up significantly. They compared that to what happened in the hospitals where they didn't run out. And again, they did worse if you were using the phenylephrine in that stage. Of course, as I said, it's not a randomized controlled trial, so there could have been other things that changing. But importantly, they've looked at how the patients who had sepsis but didn't have shock, and they're the figures at the bottom, and there's no difference there. So it suggests there was something around changing the drugs. Now, it may be that physicians weren't so used to using phenylephrine. I think experience of using drugs is an important thing. But something happened when they used phenylephrine. So again, I don't think there's evidence to support using that drug either. And this is a systematic review from Giovanni Landoni's group, looking at all different sort of alternatives to catecholamines, those non-adrenergic vasopressors. It's rather a mishmash of different treatments. So again, never quite sure what to do with that. There's all sorts of different treatments included in that. But they're suggesting that maybe non-adrenergic agents may have a potential advantage. And the most commonly used non-adrenergic agent is vasopressin. So just to remind you, it's a posterior pituitary hormone, has two roles. And in health, while we're all sitting here, it's involved in osmoregulation. It is antidiuretic hormone. So it means you hang on to water by binding to these V2 receptors in the distal convoluted tubules. However, in shock states, levels go up and it acts as a powerful vasoconstrictor, binding to the V1 receptors on vascular smooth muscle. It also binds to other vasopressin family receptors, so the V2 receptors in some vascular beds and even the oxytocin receptor, which is very similar. And in certain vascular beds, again, it's thought they might cause some vasodilatation. Whether that's good or bad in septic shock, no one's quite sure. But a couple of reasons people are interested using vasopressin in septic shock, because this relative vasopressin deficiency has been described. So normally in shock states, say in cardiogenic shock, levels go up as the patient becomes hypotensive. When they've compared that to the same level of hypotension in septic shock, the levels are often normal. And so it's been described as a relative vasopressin deficiency. In fact, probably what happens is they go up very quickly and then come down again quite quickly. So people have been interested in giving vasopressin. And the other thing that's interesting is this heterogeneity of the various receptors it binds to. And particularly within the kidney, where there are more of these V1, V1A receptors in the renal efferent than the afferent arterioles. And if you compare that to norepinephrine, which has an equal distribution, the thought is if you give these agonists with norepinephrine, you constrict both, and you might reduce GFR, whereas with less constriction on the renal afferents with vasopressin, again, it may maintain it better. And there's some evidence to support that. This small study conducted in Vancouver, 24 patients, was a proof of concept study where they randomized patients who already had septic shock, were on norepinephrine, and they added in a blinded infusion of either vasopressin or norepinephrine for 4 hours. And the nursing staff were told to maintain the same blood pressure, wean off the open label noradrenaline, norepinephrine that was running. And you can see in that 4-hour period, even though they had the same blood pressure in both groups, urine output went up with the vasopressin. So it did seem to support that it was having an effect in the kidney there. This is supported by further Canadian studies, again small, only 23 patients, but recruiting patients early, where they compared very high doses of vasopressin, up to 0.2 units per minute, versus norepinephrine. They were trying to substitute one for the other. But it was given only for 48 hours, and again, there was less organ dysfunction, and it really, when you broke it down as to what organ was had improved function, it was the vasopressin, and you can see here over that 48-hour period, the creatinine clearance was significantly higher compared to the norepinephrine arm. So again, suggesting some effect on the kidney. And of course, it's working through non-adrenergic pathways, and it works as a vasoconstrictor, and you can see you can spare catecholamine. So this was data from the VAS trial, nearly 800 patients, and you can see over time, the patients who were randomized to this blinded infusion of vasopressin were able to use significantly less noradrenaline. And is that a useful effect? Well, maybe. When we looked at those patients there, again from the VAS trial, looking at the heart rate over time, you could see there was a significant reduction in heart rate in the vasopressin-treated patients. Now, is that directly because you're taking away some of the catecholamine effects, and norepinephrine, although we think of it as an alpha agonist, it does have some beta effect. So is it removing that little bit of beta effect? Or is it a direct response to the vasopressin, maybe baroreceptor reflexes, causing that drop in heart rate? But there's quite a marked difference between the two. And most importantly, when we broke it down into the more and less severe shock groups, it was this less severe shock group that had this biggest reduction in heart rate. And if you remember the VAS trial, that was the group where there was a benefit seen. So just to remind you of the VAS trial, it was nearly 800 patients who had established septic shock, who were then randomized to a blinded infusion of vasopressin up to 0.03 units per minute or norepinephrine. And you can see the primary outcome is shown by the dotted line. There was no significant difference in mortality. By the time they were followed to day 90, maybe suggesting that the vasopressin group were doing better, but not significant. But there was an interesting subgroup analysis. There was one a priori planned subgroup analysis based on the severity of shock. And you could see that it was the less severe shock patients on the right, where there was a significant mortality reduction, both at day 28 and day 90. If you compare that to the more severe shock group, there was no difference at all. And it was this less severe shock group where we saw that heart rate reduction. As we talk about heart rate coming down, Andrea Morelli published his beta blocker study. Maybe heart rate is an important factor, and that contributed to the group that seemed to do better. It was an a priori subgroup analysis, but the problem was, the theory was, it was the more severe shock patients that would benefit. So how do we explain this result? Is it just chance? Absolutely, it could be. Hence the reason we thought we needed more trials to understand it. Could it be that the less severe shock patients were earlier in their disease process, and maybe vasopressin is better at preventing renal failure rather than treating it once it's fully established? You need to get in earlier with it. That's one theory. Or maybe the more severe shock patients had more severe shock, so they needed more drug. We limited it to 0.03. Maybe they just didn't get enough, and that was why we didn't see the benefit. So these were the ideas that we took forward, and when I came back to the UK from Canada, I set up the VANISH trial, vasopressin versus norepinephrine as initial therapy in septic shock, as I mentioned, funded by the NIHR and published last year in JAMA. And this was a factorial 2x2, and I'll explain that in a minute, but double-blind randomized controlled trial in just over 400 adult patients with septic shock. Our idea was to start the study drug as ideally as the initial therapy, but that's really difficult to do. So we said, well, we're certainly within a maximum of 6 hours. And a blinded infusion of either vasopressin or norepinephrine. And we took the vasopressin up to a higher dose. So maybe more severely ill patients will need a higher dose. So we titrated up. So as you needed, you started at a lower dose and you went up to the 0.06 as you needed. Once you got to the maximum of that first study drug, which was blinded, you then got either hydrocortisone or placebo. And this was the factorial design. The reason being, and for the sake of time, I haven't got all the time to go through it, there was some suggestion from VAS that there may be an interaction with steroids. It wasn't the main focus of the trial. The main comparison was vasopressin versus norepinephrine. But we felt we couldn't leave steroid use to chance, so we randomized that. So half the patients got steroids, half didn't. And then if you still needed more vasopressors, then you got open label catecholamines at the physician discretion, just like they did in VAS. So that was the general design of the trial. And as expected, we were able to spare catecholamine use. So here you can see the norepinephrine use. The blue boxes are the vasopressin group. So significantly less norepinephrine, but blood pressures equal between both groups. So the nursing staff did a good job of just titrating them to the target BPs. Now our primary outcome, this, remember, it's only a 400 patient trial, was renal failure free days, or the number of days that you're alive and free of renal failure. So basically a high score is a good score. So if you have 28, that means, because we only calculate over 28 days, that you survived and you never had renal failure. Now it's an odd distribution. The statisticians hate it. You can't describe it with a sort of mean or median really, because it just doesn't describe the data very easily. So the best way to show is just simply to show you the graphs and you can compare them. And you can see the top two are vasopressin, on the left with steroids, on the right with placebo, and the bottom are norepinephrine with steroids and with the placebo. We obviously tested it statistically, you can see that there, but I think the eye shows you there was no difference in the distribution of renal failure-free days, or the days that you were alive and free of renal failure between the two groups, so no difference in our primary outcome. However, in our secondary outcomes, pre-specified, there was less use of renal replacement therapy in the vasopressin group, nearly 10% lower, and you can see the confidence intervals just below 0. So suggesting that maybe there was less use of dialysis in that group of patients. Once they were actually receiving renal replacement therapy, it made no difference to the duration between the two groups. But it's an interesting figure there, less dialysis. And if you look at some of the physiological data to support it, if you look at creatinine over time, you could see it started, there was a sort of trend towards differences. It was lower in the vasopressin group. So even though there was no difference in renal failure, the actual amount of dialysis used was less. And maybe this is what the physicians were seeing. It was just slightly lower and they were getting away without using renal replacement therapy. So again, maybe some signal that vasopressin is having an effect on the kidney. There was no difference in mortality. Of course, though, again, it was only 400 patients trial, so it wasn't powered to look at mortality. What about safety? Serious adverse events were similar between both groups in total, around about 10%, which is commonly reported in septic shock trials. I think it is worth pointing out, though, when you break it down into the individual components, there probably were more digital ischemias with the vasopressin than the norepinephrine. Again, confidence intervals just crossing 0, but safety is never powered, so adequately. So I think that is an important signal to watch with the digital ischemia in the vasopressin group. But I would point out that all the patients who had digital ischemia were on high-dose vasopressors, either high-dose norepinephrine alone or high-dose vasopressin and norepinephrine together. So it's the high doses, I think, where we run into problems. There's other new data around vasopressin. This came out in print at the beginning of this year, a Brazilian study looking at vasopressin in cardiac surgery. 300 patients, similar dosing vasopressin up to the 0.06 unit as we used in VANISH compared to norepinephrine. They used a composite endpoint, and I also point out they changed their primary outcome after they started. So I think this trial does have some concerns around risk of bias assessment. But they used a composite endpoint of mortality and these post-op complications. And you can see them listed here. And the primary outcome they hit, highly statistically significant difference, lower event rate with vasopressin. Of course, it's a composite, so it's important to break down and look at the individual components. And you can see what was driving it was a big difference in renal failure, again, with the vasopressin. Much lower rates of renal failure with vasopressin compared to norepinephrine. And looking at safety profile, again, less atrial fibrillation, very common in post-cardiac surgery patients, but less frequent with the vasopressin group. So again, suggesting effect within heart rate and arrhythmias of avoiding catecholamines. So what about other non-adrenergic agents? Angiotensin II, another hormone that's involved in vasoconstriction. And this recently came out in the New England Journal, the ATHOS-3 trial, comparing angiotensin in vasodilatory shock. And this was again, smallish trial, just over 300 patients, and their primary outcome was to see, did angiotensin put up your blood pressure? That was their aim. And not surprisingly, it did. That was the target. They aimed to put it on and put up your blood pressure by 10 millimeters of mercury. And you could see more patients with angiotensin than placebo put up their blood pressure. They also report that the cardiovascular SOFA score came down. Well, of course it did, because angiotensin is not scored in the CVS SOFA, so it wouldn't. But there was no difference in organ failures overall. So I think it's interesting. It obviously works as a vasopressin. You can see it sort of graphically here. Blood pressure went up when you gave angiotensin. I'm not sure we were that surprised. But I would urge caution. We know about surrogate endpoints. Nitric oxide synthase inhibitors put up your blood pressure, and there were trials that showed it put up your blood pressure. It did what it said on the tin. But when they did the larger trials in that, with that compound, it actually led to worse mortality. So we have to be careful. I think we can be encouraged. They report mortality, and it was numerically lower in the angiotensin II group. So maybe it appears safe, particularly when they look at adverse events. There was no difference, tending to be slightly lower. Although I noticed there was no difference in arrhythmias. Again, numbers are small, but no difference there. And just again, more caution. When you look at the supplement, have a look, heart rate went up in the angiotensin II group. I was surprised when I had to go back and look it up, and it's well described with angiotensin. The heart rate goes up. So we just need to be sure what is the effect. I'm sure more trials are going to come in that area. Finally, just to talk about other things that are on the horizon, other vasopressors. Celepressin is a more selective V1A agonist that's currently being evaluated in a very interesting trial design, an adaptive design going straight through from phase 2 to phase 3, doing some dose finding and then into a larger trial to see whether it improves outcomes in septic shock. So that'll be an interesting trial to see. And there's some suggestion from the animal work and early clinical studies that maybe you get less fluid leak, and that's one of the things they're suggesting why this drug might be better, but again, we need the trials. So, in summary, I agree, my first-line vasopressor is norepinephrine, is all going well, I just continue with that. If I need to add something else in because I'm escalating the dose, I use vasopressin. I never use dopamine or phenylephrine, I see no reason to. I rarely use epinephrine. Occasionally I do, if I need some inotropine, maybe, but usually as the residents have started, and I usually try and stop it as soon as I'm involved. But about vasopressin, I use it earlier rather than later. I think if you are going to use it, it's no good using it as a last-ditch attempt. It's too late. And I use it earlier if I'm concerned about the kidney or I'm running into problems with arrhythmias and tachycardia. I do titrate sometimes up to the bigger dose, up to 0.06, but I think you need to be careful at the high doses. That's where you do run into trouble with ischemia, and maybe we accept lower blood pressure targets for that. And I think these other two agents, angiotensin II, I think it's promising, but needs more work. The celepressin is interesting, and we're still waiting, needs more work. And maybe we need to work out in the right combination of when we add these alternative agents in. Thank you very much.